Hello, everyone. Welcome to our webinar today. My name is Becky Bongiovanni. I'm the co-founder of CarePatrol. My husband, the founder of CarePatrol, Chuck Bongiovanni, is an MSW, and he began his career as a home health social worker. You know, CarePatrol was born out of the need to provide healthcare professionals with post-acute care solutions at all levels of the care continuum. And our mission is to help your patients find safer senior living options. We know that case managers are always looking for resources for their patients, especially during COVID-19. And we understand the stresses that you are faced with on a day-to-day basis. And we want to share a few ways that we can support case management and discharge planners during this time. Today, I've gathered a few of my all-star certified senior advisors to join me. And we're going to start out with Paula Sotir of Baltimore, Maryland.
Thank you, Becky. Hi, I'm Paula Sotir. I am the founder of CarePatrol Baltimore's franchise. I've been a nurse for over 40 years. That's always really hard to say. I have a master's in general administration. I'm a certified senior advisor, and just last month I became a dementia trainer. What I'd like to accomplish over the next 10 or so minutes is really to talk about 4 different things. The first thing is, there's a great company called the Advisory Board that has really looked at how COVID-19 has affected discharge, particularly through hospitals. I'm going to talk about a real case study. I'm also going to discuss how the assisted living placement process has needed to pivot during this pandemic, and a little bit about feedback from clients. You know, prior to COVID-19, there were a lot of different multiple priorities that case managers needed to think about when discharging. It's been pretty amazing that it was complicated before. You had to figure out the capacities of post-acute care as well as their capabilities. You had to figure out how quickly you needed to discharge. And if you were patient was in observation, then it might need a discharge in 24 or 48 hours. There's always different staff preferences, different family preferences, and finally, there's socioeconomic factors. And they can really guide you on your discharge plan, because sometimes folks need to go to skilled, and then maybe they need long-term care, and they may or may not need Medicare. So that's really, really been difficult for you guys pre-pandemic. Now we're in the pandemic phase. And guess what happens? You have to know which SNFs are taking clients. You also have to know, do they have available staff? Then if they have available staff, do they even have a place where they can isolate? You have to realize what testing requirements there are. And then finally, how, if you discharge home, does that put the family and the patient at risk for the virus? So that's one thing to think about. The second thing is really trying to understand, why do certain SNFs have more COVID than others? Well, the advisory board looked in California, and they really tried to compare the CMS compare scores versus the outbreak. And what they found is the lower the score, the higher the outbreak. But then leading experts said, wait, that's not right. We have to look at the link between facility size and the COVID prevalence in that community. And what they found out from 20 different states is that the larger the community or the facility, and the more prevalence in that area, then you were going to have more COVID. I have to tell you honestly, that's what happened in Baltimore City. We have really large SNFs, and we had a lot of prevalence of COVID, and sure enough, those skilled facilities were really affected. You know, it's easy to be a discharge planner in a hospital and not understand exactly what point of view the rehabs have, right, or the SNFs. And it's hard because they have 2 options. Do they accept admissions or do they not? If they accept admissions, then what they're trying to figure out is, are they putting their other residents at risk? And if they do have increased COVID, what are they doing with the community trust in that area if there's an outbreak? So they say, well, we're at risk if we accept admissions, or they don't accept admissions, and all of a sudden that long relationship they've had with the hospital could actually, could be broken. So they're really having trouble trying to figure out what to do. And I've seen that again in Baltimore, and they're struggling trying to know how to weigh both options. Where I've seen the most stress, though, is with families. Where do they discharge? It doesn't seem like there's a clear path of safety in any of them or all of them, or there is safety in all of them, and it's really hard to figure that out. So let's just talk about SNFs. So SNFs, are they available? Are they accepting clients or patients? Is there a COVID outbreak? Can the family visit? You say, oh, I don't know if I want to do that. Well, let's talk about home care. Is there availability of caregivers, even through home health or in-home care? What is their COVID policy? Can they actually accept the advanced level of care of their loved ones home? Can they walk up steps? What can they do? And then what is the PPE for the caregivers going in? Do they have enough? And do they know how to wear them? So now we say, okay, let's look at assisted living as an option. Well, who's accepting the clients? Do they have a COVID policy? Are there any outbreaks? Do they do PT and OT? And are family visits allowed? So what I have seen is that these are really, really challenging times, and we need to have more communication. We need to have more assistance to the families and the patients. We need to have more local, real-time information, and it changes daily. And then all of us need to have more empathy, and because emotions are high. What I found is that folks' coping mechanisms are already at a high place. They've already spent time trying to figure out, how do I take care of my loved ones? How do I actually homeschool my kids? Has someone in my family lost their job? And now you add this loved one that is in the hospital and they have to discharge. So it's been really challenging for clients, for sure, over the last 3 months. I always like to start with a case study to really understand what we have done. So I had a client named June. She was 59 years old. She had sepsis. It was really, really difficult. She'd been in and out of the hospital over the last months. She had unfortunately had one leg amputated. Her only leg had a stage 4 wound, and she decided that she didn't want to have it amputated. She had had a father who had a bilateral amputation, and it didn't go well. So the rehab, the SNF, called CarePatrol in, and they wanted us to really talk through what kinds of discharge options there were. And so in Maryland, the regulation is, if you have a stage 4 wound, the only way you can be admitted to assisted living is through, if you have hospice. So the doctors and the social workers did have a conversation with June, as well as the husband, as well as the sister who lived out of state. And what was recommended and what June wanted is, she really wanted to not die in a nursing home. What she said is, I really, for my wish is that I can go to an assisted living, and she knew that the outcome was not so good. So her wish was granted, and there's a picture of me on the right. I stayed there to help her actually transfer from the SNF to the assisted living. It was nice to see her. I explained that the room was ready, that the bed was there, the wheelchair was there, that the community was looking forward for her to come, and that they were planning on giving her a shower on the day she was there. It was nice to really see her smile, and honestly, I was so happy to be able to grant her wish. You know, the process for placing has really changed over the last 3 months. We've had to pivot it, and that's a word I know you've heard a lot. First of all, we had to find new ways to complete our care discoveries. Usually when we get a patient in the hospital or the SNF, what we did is we would go to those respective sites. We would talk to the nurse, the occupational therapist, the PT. We talked to the social worker. We'd see the patient. We'd talk to their family. We gather all this information. Well, what's happening now is, unfortunately, the care managers or the case managers at hospitals are doing all of this, and we know it's really difficult, but all of us need this information to help your patients. We have to have a daily log of assisted living openings. It literally changes every day, and we have to know which assisted livings are opening. CarePatrol also wrote a letter to the governor. When the pandemic first hit, what happened is, I know we didn't have a lot of tests, but we had patients that were being discharged from the hospitals, and the assisted living said we needed a negative COVID test. So we had to ask the hospital to do that, and they didn't either have enough or they weren't asked to do it because you had to be asymptomatic. Well, I know CarePatrol is not the only one that wrote letters, but finally the governor understood, and he's now allowing hospitals for clients and patients who are asymptomatic to get COVID tests. And then we're lucky to be in Maryland. I know a lot of other states do this, but every Wednesday we get information on which nursing homes or SNFs or which assisted livings have an outbreak or have any COVID. This has been really good information. It's information I give to our clients so they know, and we are up to date on what's happening in all of these sites of service. You know, it's tough. It's been overwhelming. I think you've heard me say that a couple times. We've had to narrow down the choices for clients. We know which assisted livings are open. We know their capabilities, so we narrow down the choices. And then we complete virtual tours or videos. Now, CarePatrol actually has been doing videos for 4 years. So we've had that as a way to help people understand the differences of assisted livings, but we really had to support the residential assisted livings on how to do virtual tours. We wanted our clients to know that this little assisted living, what it looked like, what the manager was, you know, what the room looked like, so that they could make a decision without ever going there. And it has worked fairly well. We have had to have a plan B, and what I mean by that, so that we meet the discharge date for the hospitals or the SNFs. What I'm finding and what I have found, and this happened 2 times last week to me, is that the family had decided on assisted living A, and last week assisted living A had a COVID, and they have to close and not accept clients for 14 days. So we now have a plan B because we want to be able to meet the discharge date. We also have been over communicating the COVID process in the assisted livings to both the clients as well as the case managers. We want to know which ones quarantine, which ones eat in the room, how do they get PPE to their staff, how has there been prevalence of COVID, has there been unfortunately any deaths. That communication is open, and we are part of making sure everyone can make decisions with data. I think for me, one of the things that has been wonderful through this process is that I have built amazing relationships with case managers. We talk all the time. It is much harder to coordinate this, and so it's been wonderful that CarePatrol can help the case managers in the hospitals. We have been really trying hard to balance the day of the negative COVID test to be the day of discharge or placement. And that takes a lot of coordination. And we've been, pretty successful in trying to do that. You know, I've been doing this for 6.5 years, and I have to say the last 3 months have been the most difficult time we've had in placing clients in safe areas. It has, interestingly enough, been the most rewarding. Here's one of our clients said, "I can't begin to tell you how helpful CarePatrol was for me during the pandemic and finding an assisted living for my dad. I wish I had known about this service when my mom became ill." You know, it takes a village. The village has been the case managers, the doctors, PT, CarePatrol, social workers. And I have to say that I'm very honored to be part of the village that has helped place so many people during this pandemic. Thank you, Becky.
Thank you, Paula, and thank you for the work that you and your team are doing to make a difference. Now I'd like to turn it over to Julie Derry in San Diego.
Thank you, Becky. So I am from San Diego, California, and I've been with CarePatrol for 4 years. I am a certified senior advisor, and I'm also, I'm conservator for my brother. I have a brother who was born with physical and mental disabilities, and so I have been his conservator for many years. And prior to joining CarePatrol, I was a corporate executive, and in building my career, I moved up and down the West Coast. And as conservator for my brother, I wanted him to be nearby so that I could visit him on a regular basis and so that I could oversee his care. So as I built my career, I would relocate my brother. And in doing that, I visited probably hundreds of group homes over the years. And I got a real sense for what it means and the responsibility that comes with choosing what someone's day-to-day life is going to be. And it really gives me the opportunity to empathize with my clients when they're choosing what will be the forever home for your patients. So that's what got me into CarePatrol. And as I said, I've been doing this for about 4 years. So one of the first questions I ask when I meet with a family or when I meet with a case manager is, who is the durable power of attorney? And the rationale behind asking that question is I want to know who's the responsible party. So in the event that this person, your patient, is not able to make decisions on their own, or at some point is not able to make decisions on their own, who can act on their behalf? And it probably seems like a pretty straightforward question, until you end up in a situation where you have fighting siblings that both produce a durable power of attorney. You've got a schizophrenic son who is power of attorney, durable power of attorney for his mother with dementia. You've got a couple, both with dementia, that are power of attorney for each other. You've got a power of attorney that can't be located. And probably the most common is that there is no durable power of attorney. And that is what I face on a very regular basis. What I find so interesting about this picture here is that you can see that they're pre-planning, right? They're actually having a conversation. What I can tell you is that all too often this conversation is being held in a hospital. I'm calling a notary and having a notary meet me at a hospital so that we can get a durable power of attorney completed, because there isn't one in place. So you might ask yourself, well, why is it that people don't have a durable power of attorney in place? And what I would say and what I've experienced is that there seems to be some fear, right? There's fear of giving up your decision making. And what's important to note in the durable power of attorney is that it's if you become incapacitated. So the durable power of attorney, you are still able to make your own decisions up until you're not. And then what a durable power of attorney does is it protects you, and that now you have someone who can make decisions on your behalf. And now what happens if there is no power of attorney, then, and you become incapacitated, then the court appoints a conservator or a guardian. So the conservator, again, it's appointed by a court. And what's important to note here is that it can be very time intensive, and it can be expensive. And it does require 2 letters by 2 physicians. So in order for someone to be deemed incapacitated, at least in the state of California, it does require that 2 physicians sign off that this person does not have capacity. So there's also a professional fiduciary, and a professional fiduciary is someone who can be retained, and that person can act on your behalf. And that can be in the setting of a durable power of attorney. Choosing someone to be your power of attorney is a lot of responsibility. And so for some people, they would prefer not to have their a family member do that because of the responsibility that comes with it. So in that case, if you don't have a friend or a family member that you want to choose to be your power of attorney, then you can go ahead and have that person find a professional fiduciary. And that person, the fiduciary, is then someone that you pay to oversee your care and oversee your assets. Okay, so now I'm going to go into a conservatorship during COVID-19. So during COVID-19, as Paula stated, there are some additional complexities that come into play. And so I'm going to give you a specific example where we used didn't have a power of attorney, used a conservatorship and a fiduciary. So in July of 2019, I was introduced by a case manager at a military hospital to a veteran and his wife. And in meeting with the case manager prior to going into the room, she had let me know that there was some concern about the wife and that she potentially had dementia as well. So I went in with the case manager. She introduced me to the couple. I spent some time with them. I took the wife to visit some memory care for her husband. And it became very apparent to me, especially as the day went on, that she too had some cognitive issues. So I reported this back to the case manager and completed a Adult Protective Services and APS report. And the husband was discharged to a skilled nursing facility for rehab. I followed the case to the SNF, met with the case manager there. And prior to discharge, we started to have the conversation again about placement, and she was just adamant that she was taking him home. So again, APS was contacted. I contacted the conservator of the county to come out and meet with me at the skilled nursing facility. Then we went from the skilled nursing facility with the wife over to their home, and the conservator and a colleague went through some documentation. They determined that the family, the husband and wife, had done what they were to do in terms of planning for retirement. So they'd paid off their home, they saved up money, they had plenty of assets to work with. However, they put everything into a trust, and because everything was in a trust, the county conservator wasn't able to work with them. So as much as none of us wanted this to happen, the couple was discharged back home. And so I worked with the county sheriff's department and with APS. We put a plan in place to provide weekly wellness checks for the family. And I became point of contact for Adult Protective Services as well as for the county sheriff's department with regard to this couple. So this went on for several months. And finally, in March, early March, probably about 10 days prior to shelter in place, I get a call from APS, and they let me know that they are going to be picking up the couple the next day, that their situation had deteriorated to the point where they just were no longer able to care for themselves, and that they were going to need to take them to the hospital. So I was actually quite relieved. I was like, okay, they're going to be cared for. We're going to figure this out, but at least I'll know that they're safe and they're getting nutritious meals. So the very next morning, I get another call from APS, and they let me know that they were not going to be able to pick up the couple, that the hospitals were unable to take new patients due to keeping beds for expected COVID cases. So is quite disappointed, but went into action. And so we had the sheriff's department and the neighbors start delivering meals daily to care for this couple. So then we go into shelter in place. So we've been in shelter in place for about 2 weeks, and it's early one morning. I get probably just after 7, I get a call from a frantic neighbor, and she let me know that the wife had been out looking for her dog that had been deceased for many years, and that she had crossed a busy street. She couldn't make her way back home. The neighbor had to go and get her and bring her back home, and the neighbor was just distraught with how to care for this woman. So I called 911, and literally had to plead with 911, right? Because again, we're in shelter in place. They're like, we can't go, we can't take them to the hospital. I'm like, no, you've got to take them to the hospital. So I got 911 to go to their home, pick them up, took them to the hospital. I got on the phone to an attorney to find out, determine what are our next steps. I then called the neighbor. The neighbor is this woman, 77 years old. She had just cared for her mom for many years who had dementia, and her mom had just passed in January. This woman is now caring for her husband who has stage 4 cancer. And I'm making a request of her to take on being conservator for this couple, because there is no family. There's just no one who can take that on. So she was very willing. We agreed to having her take on a temporary conservatorship, and that we would find a fiduciary. So she met with the attorney, began the process, and the attorney notified us that the courts are closed, but that they were open to emergency conservatorships. So we were able to initiate the process, and part of that process is that when you conserve an individual, you have to provide them with court documents that let them know that that's what's happening, and whether they can understand those documents or not. Those documents have to be served, and it has to be a signed document that those have been received. So with the courts being closed, the court system, the attorneys, no one was an essential worker. So they contacted me as an essential worker, as a certified senior advisor, to get these documents to the hospital so that they could then get to the patients. So I printed all these documents up, tried to keep them all organized as to who went to which. There was quite a bit of paperwork. And I take it into to the hospital. I can't get into the hospital lobby because of COVID. So the case manager meets me in the parking lot and signs for the documents, takes them up to the patients. And then we began the preparing for the hearing itself. This hearing was an hour and a half on the phone, myself, the neighbor, several attorneys, and the court system. So after much discussion, it was approved. So we got the conservatorship for the clients, and I am so happy to report that after 2 months of being in the hospital, the clients have been placed in a residential care home. They're doing incredibly well, and they're extremely happy. So back to you, Becky.
Oh, that's great, Julie. Thank you. What the amazing level of attention that our CarePatrol senior care advisors give to patients who are really needing to find those safe options is just extraordinary. So we really appreciate what you're doing in San Diego, Julie. Now I'd like to turn it over to Wendy Rickenbach-Barclay of Sarasota, Florida.
All right, so thank you, Becky. Super appreciate it. All right, so I hope you guys are hearing some messages loud and clear. For those of you who know CarePatrol, well, first let me introduce myself. My name is Wendy Rickenbach-Barclay. I'm the owner and founder of CarePatrol Gulf Coast, and for those of you who don't know where that's at, that is Sarasota County. And everybody who knows anything about Sarasota, it's lovely, beautiful, we're right on the Gulf, they love it. Not only am I a certified senior advisor, I'm also a certified dementia practitioner, I'm a transitional care manager, and most recently I became a certified Alzheimer's and dementia trainer. So really, really focused in, and I would say if I had any area of specialty, it would be with those who are cognitively impaired. But I wanted to touch base before I move forward and just take a moment to pause, because you just heard from two very skilled, very collaborative individuals, Paula and Julie. And a lot of times people, when they hear CarePatrol or they know anything about, they think we just work with seniors. Well, I don't consider a 59-year-old a senior, maybe because I'm getting closer to that age every day, but 59 seems pretty young to me. So that's what I would say a non-traditional type of person that we partner with hospitals and case managers with that sometimes wouldn't connect the dots, like who in our community can partner with this to make this happen. And then I also want to point out with Julie, I don't know, I did some basic math. From the time Julie got involved until the time these folks were safe was almost 8 months. Now, clearly, those of you who work in hospital rehab settings don't have 8 months to spend coordinating community resources and pulling in those resources to make sure your patients are safe. You typically get about 3 days to turn that train around and figure out something safe for them. And I know your hearts, because I work with our case managers here locally, most of them are nurses, your heart wants to help them, right? And so we're gonna talk a little bit, why would a case manager need a transitional care manager? And that's somewhat of a new term in the industry, but you're gonna find that, you know, I don't like the word placement, because I feel like placement just a tiny bit of what we do. Our goal, just so you know, is to educate every single family, every one of your patients, so they can make informed choices, right? That's most important. And we feel like the placements take care of themselves, and they do. So the goal is to educate and empower people, because they are overwhelmed. You heard Paula talk about communication, communication, communication. Most case managers, you guys have your script, right? There's so many things you have to get through, and we're gonna dig in a little bit deeper. So let me just move forward here. All right, so let's see if this sounds like your day at all, because I'm usually embedded in your day, but you have a full load of patients, right? They all have discharges, everybody's staggered. You're trying to get orders from doctors and therapists and maybe get updates from the nursing team, all while trying to communicate with your family and say, here's the options, here's next steps. And where does everybody want to go? They want to go home, right? They want to go home. But let's just frame this up. They're telling you, the case manager, they want to go home. And you're like, all right, how do we make that happen? And how do we make it happen safely to get that safe discharge? And you're there again, going through your database and your Rolodex of options. And, you know, let's just make up something here. All right, let's just say they have 2 to 3 comorbidities. They're at least age 75, if not older, and they're needing assistance with their activities of daily living. All right. And so you're thinking to yourself logically, or maybe they even have some cognitive impairment, throw that in the mix. And you're thinking to yourself, if I send this person home, you know, even with home health, right? Are they really going to be successful in that environment? So how do we partner with someone to help make that a successful transition and keep them safe? All right, so lots of things happening very quickly. Then what they do is they graciously share with you, well, my kids are flying in. They're going to help out. Now, I don't know about your families. I'm a kid. I've got aging parents who all need care. And when I fly in to help, I'm not staying for a couple months. I'm like there for 3 days, 5 days, a week tops, okay? I love my parents, but I also run 3 companies. And so and I have my own family and my own set of responsibilities, you know what I mean? So loving them, caring for them, and also being responsible in a lot of other areas. So the kids are gonna fly in and they're gonna help out. They're going to take care of all these things. And so there again, you've just went through everything that you needed to do. Now we've got a new player in the scene, right? So now we got to get the kids up to speed right away. Here's another really famous scenario that you guys probably encounter, is that we have 2 seniors, 2 elderly seniors. They probably both have something going on, or maybe one is really healthy. Heck, I'll give them the benefit of that doubt. But all of a sudden, you've got a patient that needs assistance getting in and out of bed, on and off a toilet, in and out of a couch, in and out of a chair, maybe in and out of a wheelchair. I mean, there's a lot of things that could happen. And is that person physically able to do that? And so, you know, there again, your mind's probably reeling. And all this, we're gonna dig a little deeper into your day, because this is just tip of the iceberg. This is the easy part of your day, right? This isn't even where rubber meets the road for what you have going on. Let's just go a little bit deeper. So there's a lot of things that happen in the course, meaning, you know, you guys have your challenges that you're faced with, but then also your hospital or rehab, they have their goals and objectives. Your family has their goals and objectives, and everybody's trying to figure out how to make that work together. Now, I don't know if you guys know this, but about over 80% of seniors over the age 75, and I should have referenced the websites I pulled that from, I'm so sorry, but over 80% of seniors over age 75 with 2 to 3 comorbidities could go home if they had a true caregiver, meaning somebody's willing, competent, and capable. So they may be willing, maybe they are not competent, we don't know that yet, but that capable piece comes into play maybe from a physicality. Can they physically do some of the things I was just mentioning? So here's the gig. Your hospital is a business, right? Your rehab is a business. And so they're trying to run the day-to-day operation of their business, which is serving patients in the community, serving families. But at the same time, they've got to be profitable. They're looking at how they get paid through Medicare, and they're looking at a lot of stuff that really probably means a whole lot of nothing to you every day, which is fine. But when you want to know why your leadership's, I always say, kind of raining down on you, it's not that they dislike you. They have goals and objectives being driven from above them. And at the end of the day, your family just wants to be safe, right? And they just want to go home. And so just a lot of challenges that you guys face on a day-to-day basis. Now, I want you to pause for a minute and think about what if? What if you had a certified transitional care manager? A transitional care manager whose goals and objectives directly aligned with yours. Someone who works in tandem with you, doesn't cost you or your hospital rehab any money, and they're going to stay with that patient for 30 days or longer upon discharge, which I think Julie gave that good example. 8 months. I will tell you, tip of the iceberg. I've got families that I've been with for years at this point, and we just keep reaching out, touching base, you know, whatever the case needs to be, trying to move the needle for safety, whatever that needs to be for that family. Now, I love when you guys get somebody, I don't know if you've had this, I'm sure you have, because every single day I get faced with, my mom and dad, they can just go to rehab. They can just go to rehab. They have great insurance, right? They got great Medicare insurance. They get 100 days of rehab. And you're thinking to yourself, you can't send every single human being to rehab, right? There's criteria that people have to meet to go to rehab under Medicare guidelines, you know? And so you're thinking to yourself, not everybody, but they're like, they get 100 days and they're not realizing that Medicare, I say this all day too, if y'all want to write this down, grab your pen and paper. Medicare is medical insurance, not activity of daily living insurance. I'm going to say it again. Medicare is medical insurance, not activity of daily living insurance. Now, that's not to say if somebody has like an episode of some sort, you know, and they need some nursing services brought in temporarily, like help with showers or this or that, Medicare can help cover that. I also hear this, oh, we're going to send in home health. My mom's getting home health. I'm like, all right, well, that's about 2 to 3 hours a week. Who's going to help her like all day long get in and out of bed and out of the toilet and out of chairs? Who's going to take her grocery shopping, get her to her doctor's appointments? Who's doing all that? Because typically your home health is going to be your PT, OT, speech, and nursing service, right? Somewhere in their mind, in their brains, I don't know, it sounds like when I talk to them, they're getting 12 to 15 hours a day of somebody hanging out with them, helping them out with stuff. Not the case. So I hear it all the time, and you know, a lot of times families also don't understand about how their benefit days work, and not that we want to really be experts, although we all are kind of experts. The reality is they need to understand how it all works together for the greater good. So what is a true transitional care manager? So I've just pulled up, a transitional care manager is a credentialed expert at transitional care, especially from a hospital setting to wherever a patient's next step is, whether it be home, rehab, or a community-based care setting, AKA assisted living. So, you know, that's what they're going to do. So it sort of sounds like what you guys do, but we kind of pick up where you leave off. You guys are experts within the confines of your hospitals and the day-to-day processes and systems and procedures. We kind of are your external person who's managing all the things, like what Paula said, how we have the latest updates on who has availability with the assisted living, the SNFs. We're reviewing care and violation history. We're going to dig a little deeper some of the other things that we're doing, but even from a funding strategy, because I can tell you what I hear every day. Oh, my mom can't afford it. My mom can't afford no care. You know, it's expensive. She's got to go to that rehab, right? Get that 100 days. My mom she can't afford care. My mom has $1,400 a month. I'm like, okay. So interestingly enough, that same $1,400 a month client, not in all cases, but about 70% of the time, 60 to 70% of the time, we can usually educate families with the various funding strategies to keep moms safe, whether that be at home or a community-based care setting, meaning private duty care, right? So they're getting home health that 2 to 3 hours a week. How do we augment that with private duty care, right? Not the neighbor who's going to go pick up the laundry or a prescription or drop off a meal, but someone who's going to help with those activities of daily living. And what does that look like, and how do we pay for it? And I will tell you that's usually where most people's objection comes from, is from the money perspective. And it's like, oh, she can't afford it. So we got to help people figure out how to afford long-term care, because quite honestly, they didn't plan for it. If you talk to the seniors of today's generation, you know, those 83 to 86-year-olds and up, they didn't think they were going to be here that long, right? So they didn't plan. They didn't plan. I can assure you, our generation should be planning. Anyways, so a true transition care manager should be able to make an immediate and positive impact on your day-to-day. And what I think you're going to find that a transition care manager is going to give you very fluently is the gift of time. The time you wish you had throughout the day to really spend with each and every one of your patients and their families, to really drill down all the different care options, how to put that puzzle together, whether it's short-term or long-term, pending their physical, mental disposition. Obviously, you've got to have a partner that's going to be with you to meet the discharge goals. And also, quite honestly, we want to reduce readmissions. All right. So hopefully, if you guys have any questions, you'll reach out to us. There's going to be a dedicated phone number that you guys can reference, and we're going to repeat that at the end of the call. But I want to thank you for your time, and I thank you, Becky, for sharing me in.
Thank you, Wendy. What a great summary of the services that we provide. Okay, so next up, and our last speaker today is Victoria Archable of Metro Atlanta, Georgia.
Thank you very much, Becky. Hello, and thank you, ACMA, for this opportunity to speak with your members. I am Victoria Archable, the owner and certified senior advisor of CarePatrol of Metro Atlanta. I'm also a newly minted certified dementia practitioner. I will be speaking with you today on the subject of what it takes to improve patient outcomes. I believe, and I have seen over the past 6.5 years of working in senior care, that it takes a village. I like this quote that I came across by Steve Wheeler. Everyone in a village plays a specific role in the community, even the village idiot. Villagers tend to help each other out more readily because of their strong social ties. We have seen this happen throughout our life and throughout history. Most recently, and even still today, we have seen the village come together during this awful crisis that's hit our country and the entire world. During the corona pandemic, we have seen people lift up our amazing heroes in the healthcare field. People have made signs to encourage everyone. They've delivered grocery to those isolated in their homes. People have made masks and donated masks. They've made meals for their neighbors and those and entertained the elderly living in long-term care facilities who are unable to have family and friends visit. It has taken everyone pulling together to get through this crisis, and we still have a long way to go. But we know that the healthcare system is facing an impending challenge. We'll talk about solutions a little later, but right now I'd like to set the stage. All of you know that 10,000 people turn 65 every day in this country, the so-called baby boomer generation, of which I am a member. Experts predict that between 2016 and 2035, the 65-year-old and older population will nearly double. Y'all, that's a lot of old people. So what, you may ask? Well, we know that there are some serious consequences to aging. For instance, as we age, we develop more chronic health conditions. We also see an increase in dementia-related illnesses. Healthcare costs continue to rise and will continue to get even worse. We see more stress on families as they really struggle to figure out how to care for their aging parents or loved ones. There is tremendous stress on the healthcare system, and as all of you know firsthand, there is more stress on you. But what if we started to reimagine the entire healthcare continuum? What if, along with advances in technology such as telemedicine, hospitals would include supported living or custodial care as part of the continuum of care? What if, as part of the ACMA's Transitions of Care Standards, we could imagine moving from strictly a medical model to a social model where appropriate? What if assisted living was added as an option to the long-standing continuum of care, which has always included home to hospital, hospital to home with home health, or to a SAR? So what are the benefits of discharging a patient to assisted living instead of going home or to a SNF? Well, depending on the patient's needs, an assisted living community could help with activities of daily living, such as meal preparation, bathing, dressing, grooming, toileting, and many others. We know that medication management is a huge issue with the elderly and is a factor in how well they recover post-hospitalization. In an ALF, that task would be managed for them. What about isolation and loneliness among seniors, which we know has a negative impact on their physical and cognitive health? In an ALF, they have companionship and can engage in social activities all day, every day. Most communities provide transportation to their residents. Now, for a spouse or a relative who is the primary caregiver, having their loved one in an ALF can greatly reduce the stress of being a caregiver full-time. And finally, most assisted living communities strive to allow their residents to age in place, thus avoiding the need to move to a long-term care facility if their health declines. We at CarePatrol know that the goal of the ACMA is to deliver patient-centered care and engagement. And that's a worthy goal, but it takes a village. We hear every day from seniors or their adult children that they are just overwhelmed trying to navigate the system of care by themselves. They have so many questions to ask. When you tell them that the doctor advises that their mother or their father not go back home to live alone, it's just not safe anymore. They start to ask, what are my options? Am I doing the right thing? How do we pay for this? Where do we even begin? Well, at CarePatrol, we believe together we can meet the challenge of helping your patients and their families figure out these questions. Our senior advisors provide the hand-holding that your patients and their families need. We are local experts that know the best care options and can guide families in making safer choices. And best of all, we are a free service to your patients. Clients around the country rate our service about as high as you can get, a 4.9 out of 5, based on the independent review company Trustpilot. And you know what else? We have our own village that we have cultivated over the years because helping families means more than just placing them. We bring along other resources in the community that are often needed by families, such as geriatric care managers, senior move managers, elder care attorneys, VA claims agents, and others. We strive to be a one-stop shop for your patients. And oh boy, when you partner with CarePatrol, the payoff is enormous. We see an improved discharge process because we help your patients get out of your hospital on time. Number two, we see reduced readmissions. When they discharge to a safe environment with watchful oversight of medications and nutrition, oftentimes we see readmissions go down. We see a reduction in healthcare costs. Obviously, if we reduce readmissions, we hope to flatten the curve of rising healthcare costs. And all of these benefits equals the best benefit of all: improvement in patient outcomes. Thank you for your time today. We hope that you will make CarePatrol advisors part of your village to improve patient outcomes.
Thank you, Victoria. So I really hope that these stories from the field have resonated with you as case managers and discharge planners. I think you can see the level of care and attention that CarePatrol provides beyond what happens inside the hospital. And, you know, we hope that we were able to educate some of you on the factors happening in senior placement during COVID-19 and even beyond. And so, in summary, we are a no-cost service to you. We want you to know that we're here for you, and we want to hear from you. So to speak to a local senior care advisor in your area, we have provided you with a special website for the ACMA, and it's simply bit.ly/care ACMA. Or just simply give us a call at 888-631-7181. And you can also check out our resources within the special COVID-19 issue that the ACMA has sent. Thank you all so much for being a part of this webinar, and thank you for everything you do every day to enhance the lives of patients.